everyone. Why don't we start? As I mentioned, please feel free to help yourself to refreshments in the back. And we are deeply honored and delighted to have with us this evening Dr. Bernard Lowe. He is a professor of medicine emeritus and director of the program in medical ethics emeritus at the University of California in San Francisco. He's also the president of the Greenwall Foundation here in New York, which has been one of, if not the only, major funder of bioethics research and work in the United States for a number of years. We're fortunate to have had the prior president of the Greenwall Foundation, Bill Stubing, speak to us a few years ago, and there's a wonderful recording of his talk, video of his talk on our website if you're interested. Dr. Lowe is a member of the Institute of Medicine, National Academy of Sciences. He has served on the IOM Council and has been the chair of the IOM Board on Health Sciences Policy. He is a co-chair of the Standards Working Group of the California Institute of Regenerative Medicine. He has also been a member of the board of directors of AHRP, the Association for the Accreditation of Human Research Protection Programs. His book, Resolving Ethical Dilemmas, a Guide for Clinicians, is in its 5th edition, and I heard he's working on a new edition of it. He has published around 200 peer-reviewed articles. He's really one of the major figures in bioethics in this country, and we're deeply honored to have him with us this evening. I should say this is also being live streamed, so people who are watching us live stream, welcome. Please feel free to email us questions, and during the Q&A, you will have a chance to have those questions asked, or at any point, please feel free to ask questions. So without further ado, please join me in welcoming Dr. Lowe.
Thanks, Bob. It's a pleasure to be here. Appreciate the invitation. I had a little adventure on the one train, which we can talk about over dinner, but I'm learning. It's always good to learn about a new line. As Bob said, I wear several hats. I'm president of the Greenwall Foundation. Our mission is to fund research in bioethics. And I also still see a small panel of primary care patients at UCSF in San Francisco. The remarks I'm going to make today are my own. They're private. They're not in any way to be construed as the views of either the Greenwall Foundation and certainly not the University of California. So I'm actually working on a paper on this topic, so I asked Bob if it would be okay to kind of try out some ideas. So I really will appreciate feedback, questions. My remarks are going to be relatively brief. I really want to hear your thoughts, your reactions. But I'm glad to talk about other things in the Q&A. Dr. Klitzman mentioned that sometimes you like to hear speakers talk about how they got into bioethics and what got them started and things like that. And if people want to ask, I'll be glad to try and discuss that. And one thing I wanted to ask you is how many of you are physicians or nurses in the audience? Oh, a number, okay. How many of you are medical students, so physicians? Oh, okay. They're all studying in the library? Okay. And the rest of you, I take it, from other fields. Great. So what I want to talk about today are the ethical dilemmas that come up when patients ask doctors questions about physician aid in dying. So much of the discussion has been around should it be legalized, the arguments for and against, what should statutes look like. California recently legalized physician-assisted suicide. They're now implementing it. A lot of issues with regard to regulations, institutional policies. I'm not going to talk about that. What I'm going to talk about is sort of what my roots are, which is when you're in the room with a patient or at the bedside and they ask you a question. And I'm going to tell you real briefly about 2 cases that I remember. One is a man in his 70s. He's a retired Air Force pilot, sort of very direct person, but likes to chat a little at the beginning of the visits. he often does it in an offhanded manner. And once he said, "Doctor, what do you think about this new physician aid in dying?" And he said it casually, almost as if he said, "What do you think of the new parking lot that just went up? Is it a good thing?" So what is he really asking? But then at the other extreme, a patient who made a really straightforward request. She looked me straight in the eye. This is a woman with progressive metastatic cancer that had a lot of really severe physical symptoms that were refractory to both disease-oriented care and palliative care. And she looked me in the eye and said, "Are you going to write me a prescription so I can end my life?" And she stopped for a minute and then looked at me and said, "If you were a veterinarian, you would do that for my dog if he was suffering even a little, half as much as what I am." So direct request. She looked me right in the eye. Okay, so what I'm going to try and talk to you about today is that if you were in a state like California, Colorado, where ballot measures, Assembly, Senate bills were discussed, you probably thought about, where do I stand on this? Which way am I going to vote? Am I going to tell my state assemblyman to vote up or down? And there's a lot written about that. It's been really discussed and some really thoughtful pieces written. But I'm going to talk about what happens after that. So there are now 7 jurisdictions that comprise 18% of the US population where physician aid in dying, as it's now called, is legal. And I'm going to argue that, especially those of you who are younger physicians, you're going to get these questions. We know that even in jurisdictions where it's not legal, people get asked. So 20 years ago, a national survey of doctors asked them, had they been asked about, at that time it was called physician-assisted suicide. And 18% said they had been asked at least once in their career. And even beyond that, 11% said they had been asked for active euthanasia, so assisted suicide. So aid in dying is kind of a term that different people use in different ways. Writing a prescription for a lethal dose of medication the patient takes, which is legal in these 7 jurisdictions, doctor writes the prescription, patient takes the medicine. Active euthanasia is the doctor administers a drug with the intention of ending the patient's life. And that's illegal in all states, but it's legal in some countries, in Europe, Holland, Belgium. So I'm going to try and argue that if you've thought about the issue and you really took seriously voting for a ballot measure and thought about the issues and you made up your mind on should it be legalized as a matter of law, that may not prepare you for the questions you'll get from patients. And many colleagues in California are struggling with that. It's a lot harder than they thought, and it's a lot more complicated than they thought, because it's far more than just deciding to write a prescription. And we'll talk about that, and maybe that will emerge in the Q&A. So, a couple of big areas. First is to clarify what the patient is asking. So the 2 examples I gave, they might have been asking very different things. I think the first thing is you have to get a sense of what is the patient really asking and what propelled them to ask that. And the reason I think that's important is you don't want to answer one question when the patient is asking another. Turned out for the first patient, it wasn't quite just a casual thing like, what do you think of the heavy rainstorms we've been getting? He was concerned about a family member with Alzheimer's, with dementia, and wanted to talk about what was coming. And this was a way of easing into that. Now keep in mind that Alzheimer's is not one of the conditions that it's clear fits under the laws in Oregon, Washington, and California. My second patient, as it turned out, she really wanted that prescription. She said, look, you've sent me to the specialist I've seen. I like my palliative care doctor, but these symptoms are just, they're wearing me out. I can't sleep. She had trouble swallowing her secretions because of an obstruction. So you have to figure out what are they asking and try and address that question and concerns. So the second thing, this is always good medicine, right? You explore, you're a psychiatrist, but you explore the patient's concerns. And there's been lots of good articles written about how you do that, the value of open-ended questions, empathic comments, to sort of get the patient to explore with you what those concerns and needs are. I think the reason that's important is that then you can identify unmet needs which may be responsive to palliative care, what you do. And that's one of the wonderful things that's happened in the 20 years since that original survey was done. Palliative care has blossomed. I mean, we do a lot better job, I think, taking care of symptoms, and taking care of comprehensive symptoms than we did. And the other thing I want to try and emphasize is that this is not a single conversation. This is likely to come up, and it shouldn't be a single conversation. I mean, most of the state laws require the patient to repeat the request. And what you really want to do is see if, by intensifying palliative care, the patient really doesn't need the lethal prescription. So every time you have that conversation, I think you have to go back and sort of explore what the current concerns and needs are. Okay, so now I'm going to branch out. For those of you who are supporters, or at least supported the legalization, there are a set of questions that follow. And a couple slides later, we're going to talk about, for those of you who are opposed, there are different issues that come up in the clinical context. So one thing, for those of you who, if there were a ballot measure, would have voted for it or decided to if you already had the chance, would you assist any patient who meets the legal requirements in your state, or only in some cases? So the requirements are pretty similar, but terminally ill patient who's competent, makes an informed request, and usually there's some sort of waiting period and repeat. And certainly good practice is to refer to palliative care. There are a lot of conditions that, I don't know if this is on a timer or you're just trying to get me to talk faster. There are a lot of concerns and conditions that lead patients to either just inquire or to request. Now there's quite suggestive evidence in the empirical literature that if you talk to doctors about what cases do you have in mind when you're thinking about should physician-assisted in dying be legalized, the case that many physicians will focus on is the, these days, very rare case of the patient with unremitting pain from metastatic cancer, for example, which is just not being palliated with the best palliative and disease-oriented care. Now that's actually pretty rare these days, because with palliative sedation as kind of a more generally accepted palliative care modality, unremitting refractory pain is a lot rarer. But I think if you ask a doctor, tell me a case where it's the strongest case, it's cases like that. But these days, that's not, if you ask patients who are making a request for physician aid in dying, that's not the most common reason by a long shot. The most common reasons now are loss of autonomy, loss of dignity, a feeling that their life is no longer worth living because it's so diminished. So very subjective concerns, very important concerns to patients. If you talk to patients, I have a very wonderful sort of 98-year-old patient who is sharp as anything, and she's going to a museum and said, but she didn't want to walk from the parking lot. Could she get a disabled parking sticker even temporarily? But she said, if I went to sleep and didn't wake up, it would make me so happy. My first husband died, my second husband died, all my friends, people I grew up with, they've passed on. I love my children, I love my grandchildren, but my life is really complete. She doesn't qualify for the California legal physician aid in dying, but her concerns are really a loss of dignity in her life. Even though to an outsider, she's pretty active. So I think you will get requests, and then you have to ask if you're in a state where it is legal to write that prescription. I could do this. Legally, I'm now permitted. But is this something I think is clinically and ethically appropriate that I would do? And there will be variation from doctor to doctor. If you talk to colleagues, some of them will have a fairly expansive view, and others will have a narrower view. So you only figure this out, I think, when you're first asked, because otherwise, until you really see the decision embedded in the case, it's hard to really get a flavor of it. That's a hard question to have to answer, because the last colleague I talked to said, well, I thought I'd figured it out. I read a lot, thought I voted intelligently, and I didn't expect this situation. Second thing is, if you're committed, if your evaluation is that the patient seems to qualify, but you're going to take them through all the sort of legal checklists, it takes an incredible amount of time and effort. This is something that most physicians have not done before. It's new. If you think about those of you who are physicians or those of you who might become physicians, if you're being asked to prescribe a drug you've never prescribed before, you're going to want to do some reading and maybe do a quick CME on the web on the latest drug is for diabetes or heart failure. You can't find articles like that on this topic. You can find advice, and certainly advocacy groups and individuals will give you very specific advice. But in terms of something that's more evidence-based and something that's balanced, it's really hard to come by. It says no PubMed search. I checked again a couple nights ago. So what drugs, and the drug regimen is now changing because the price of drugs has skyrocketed. The drug that was formerly used, one of the drugs in the phenobarbital class, a lot of pharmacies don't stock it. A lot of insurers don't cover it, so there's an out-of-pocket cost, which can be several $1,000s. And so if you've walked along, you give the patient a prescription, it's like when I give a patient a prescription for the latest heart failure drug or diabetes drug, and the patient says, well, my insurance won't cover it. And I'm told it's, the 30-day supply is $480. I can't afford that. So access to drugs, out-of-pocket costs. If you're a conscientious doctor who takes a broad view of your role, not just writing the prescription, but sort of seeing if it makes sense for the patient, that's a lot of new information to try and find out. And we can maybe talk about what institutions are doing or not doing. Okay, not only that, when I prescribe a new drug, I like to sort of know what's its likely chance of success and what are the adverse effects if the patient's asked. Well, it turns out the standard regimens that are prescribed for physician aid in dying are not without adverse effects. And there are actually pretty good studies that are done, sort of tallying up the adverse events that occur. Not uncommonly, well, it can take a longer time for the patient to lose consciousness or to die than either the patient, the family, or the doctor thought. And that, I'm told, can be very difficult. There are other adverse effects. I mean, these drugs can cause vomiting, and that's certainly not what the patient and family expected. And in rare cases, the patient will actually gasp. And it really, I've not seen it, but descriptions of it are likely to be alarming to anybody who's there. Now, if something happens, if the patient has gathered friends and family, said goodbye, ingested what the doctors prescribed, and things go badly in these ways, the family may not have a whole lot of sense of what to do. And as so often happens towards the end of life, the thing that people do know how to do is call 911. And that triggers a whole set of medical interventions that may or may not be good for the patient. So how much do you talk about pulse forms, do not attempt resuscitation orders, things like that?
Thank you very much for that extremely dense.
My own sense is that just when I prescribe a new antibiotic, and the patient wants to know, well, is this going to give me diarrhea like the last one? Is it going to give me a skin rash? Am I going to get a super infection, a fungal vaginitis? Sure, you'd want to know what's going to happen to you. Okay, a lot of patients and families would feel comforted if, assuming that they qualify, the doctor is unable to persuade them to offer palliative care that relieves the symptoms, they continue to want the medicine and decide to take it. Many people, and we don't know exactly how many, ask for someone to be present from the healthcare system. Now, who is that? Is it the visiting nurse? Is it the hospice worker? And that leads to a whole set of questions. Is there someone who works in hospice who personally is willing to do that? Because you have to let people say that that's beyond their personal, religious, moral beliefs. Does the institution allow it? So different hospices have different policies. And so, again, if the patient asks, how do you find out? And what if the patient asks you as the prescription, as the doctor who wrote the prescription, will you be there? Now that's a question that's really different than were you willing to vote yes or no on a ballot. Some doctors, and again, there's a wide variation. I know doctors say, sure, that's part of taking comprehensive care. And others say, wait a minute, people can change their minds. And if the doctor is there, maybe they're not as comfortable saying, well, no, I'm not quite sure. Okay? So these are complicated questions, and I'm not sure having decided for yourself how you're going to vote helps you with this. And it's not easy to do real time. Okay. Now, one thing that strikes me, so many people say what they want at the end of their life is to be able to control the manner and time of their death. And, all drugs have adverse effects. All drugs have cases where they don't work. And so there are no guarantees. There are probabilities, as with every other drug that gets prescribed. And so I think it's important not to have an unrealistic sense of what's going to happen. Okay, how about opponents of physician-assisted dying? So, again, the country is split. I think physicians as a profession also have disagreements. So one thing I think if a physician or nurse or pharmacist perhaps has a personal moral, religious objection, most state laws say they can opt out. Okay, they don't have to write the prescription, they don't have to, they may not have to fill it. And it's important to protect the sense of integrity of our fellow citizens, colleagues, and also respect their conscience. You don't want to force people into doing something that, although legal, is something they have a very strong personal objection to. And it really, I think what's different than some of the recent Supreme Court cases is that for many people it really strikes at the heart of what it means to be a doctor, what the appropriate role for a doctor or nurse is. So it's not, I would try and distinguish this from the bakers of cakes, for example. But that fact that you're not going to write the prescription, even if you say that to the patient, we'll talk about in a couple minutes, does not solve a lot of the other questions that you're going to face. So some doctors may be concerned that just talking about physician aid in dying might encourage the patient, sort of suggest that the doctor is supportive, or make the doctor complicit in something that she thinks is morally wrong. So that's an important point. But I want to sort of ask people to sort of analyze a little more of what you mean by complicit, because it's a word we use, but it's hard to analyze. So in fact, there are data to suggest that continuing to care for a patient who asks, and actually I would argue even a patient who's gotten the prescription he sought from another physician, continuing to care for that patient does not make you complicit, does not provide support. And in fact, you could argue that it offers an opportunity to continue to relieve the patient's suffering, to give palliative care, and to provide opportunities to change the patient's mind. And my own sense is, or what I try and argue, is that particularly with patients you've been seeing for a long time, it may be in primary care, or if you're an oncologist, a patient that you started on adjuvant chemotherapy after surgery when you thought she was going to be cured, and then gave the first salvage therapy and the second salvage therapy, you've had a very long-term relationship. That relationship gives you particular insights and opportunities, and patients really listen to you and trust you in ways that they wouldn't necessarily a new doctor. And in fact, the data show that people who inquire about physician dying don't always request it. And even if you request it, the first time doesn't mean they go on to get the prescription and use it. So almost half the patients of people who make an initial request change their minds after the doctors have given just more effective, more intensive, more creative palliative care. So in fact, you have opportunities to remove the reasons that led the patient in the first place to make the request. Even more than that, even if patients get a prescription and fill it so they're sitting in their medicine cabinet, a substantial percentage, 1/6 to a quarter, who get the prescription don't use it. Now, why is that? Well, I've had people say that they knew a patient, or patients have said, I wanted it as a last resort. If things really got worse, I knew there was still something I could do, but didn't mean they necessarily took it. So I would argue that if you're an opponent of legalization of physician aid in dying, this is an opportunity to continue to work with those patients so that the reasons that led them to the request are no longer operative. Now, having said that, I think it's very important that you state clearly to the patient what you're not willing to do. I don't think you necessarily, well, I actually would discourage people from sort of giving a philosophy or theology lecture. But I think it's really clear that you state clearly, your limits and why. And I think, again, there's suggestive evidence, qualitative evidence, good qualitative evidence, thoughtful evidence, that patients and families are willing to work with a doctor who says, I know you made that request, I'm trying to alleviate your suffering, but I cannot write that prescription. They may continue to want to see that doctor because of the quality of the relationship. Okay, so another thing I want to think about is, so there's a lot of talk about the physician's own moral integrity and conscience, either to oppose or to say, this is now part of my job and I'm going to put a lot of effort into doing this well. I've talked a lot, not so lot, I hope it's not over the top, about the doctor-patient interaction with the specific patient who asks or requests. But what a doctor does, and arguably perhaps what the institution does, has an impact on other patients. So in Oregon, which has been collecting some data since their law was passed, about 2% of doctors said they had a patient leave their practice because of their position on physician aid and dying. Now, they didn't specify it's because they were supporters or opponents. But you can sort of think through a scenario, and again, it's like a branching logic chain. If the doctor's opposed and the patient would like to have it as an option, the patient may say, let me find a doctor who is compatible with my position. And the other way around. If the doctor is a supporter and the patient is staunchly opposed, there may be concerns that, well, is the doctor going to suggest it, subtly suggest that, maybe it's an option. Now, there's older data, again, it's about 20 years old, when a national study was done of oncology patients, cancer patients. Almost 1 in 5 said they would change doctors if the doctor said he had provided physician aid in dying. That assisted suicide at that point. Okay, now if you think about what it's like to be a cancer patient, to go through chemotherapy, if your focus is on trying to improve your quality of life and your duration of life, and for you, physician aid dying as a patient is not an option, you may well want to switch doctors. So I think it's not just a patient from the room, it's other patients. There's all kinds of questions of, do you only tell the patient who asks you? Do you sort of let people know? I mean, you could imagine, for example, a patient starting oncology care where things are, still hopeful, wanting to not develop a relationship only to find out later that they hold such divergent views. Okay. So finally, I want to say these are really hard decisions. I'm impressed with the number of colleagues who say, this is hard. It's a lot more complicated than I thought. It takes a real emotional toll on me and a toll in hours to do this well. And it's also hard, frankly, because your own emotions come through, that your own thoughts about dying, death, reminders of deaths in your family, it all gets wrapped in. So these are some of the most difficult situations. one of the things that I try and do, and it really, again, doesn't matter whether the doctor is a supporter or opponent, is to try and take them back, help them think about, what do you do in other situations when you have a really tough case? And I think the first thing I do, and I always advise, is to find someone, a trusted colleague who's really smart, and run the case by. Because a couple things might happen. First, they may say, have you tried this in palliative care? Hey, that's a great idea. Let's tell me more about how I would do that. Or your colleague may say, well, when they asked that question, what did you say? Have you thought about saying this instead of what you said? So to improve the quality of the interaction. None of us are so good that we can't learn from others. The other thing is that every one of us has, I hope we all have figured out what helps us when we're under a lot of stress. And it's, again, all very personal. Talking to your spouse, your friends. Do what relaxes you. And for some people, it's taking a walk outside. It's what I do, ride my bike up in the hills. Other people say, that's nuts. Some people play music, some people pray. But do what has worked for you in the past. And finally, I just want to say, those of you who have attended funerals and memorial services for patients, it is really amazing how grateful the family is. And, I may feel, boy, I wish I had done a better job, or, a patient really wasn't comfortable the last week. And the family doesn't focus on that. They focus on, you were there, you talked to us, you tried to provide, relief by just being there. They say amazing things. It really means a lot to them. So let me just stop there and say, glad I had a chance to talk, and I'm just going to throw it open to questions. And please, I'm delighted to try and address anything that you want to talk about.
And we have monitoring the questions online, right?
Yes.
Okay.
I actually have a question online.
Okay, but let's give priority to the people who are here.
First, we'll give the people here a chance. Questions? Yes.
Please.
Well, why don't you just introduce yourself, if you don't mind?
I'm not at all. My name is Judith Schwartz. I'm the clinical director of End of Life Choice New York. And I actually work with terminally ill and incurably and progressively ill patients in New York State who are interested in getting information about options and choices at the end of life. And we do talk about the possibility of being able to control the circumstances and timing of death. So I appreciate what you've said, Dr. Lowe. It's been very interesting and informative, but I do have some questions. You talked about physicians' absolute right, and I certainly agree, to take a moral exception to assisting somebody in hastening or controlling their own dying. But I wondered, you didn't mention whether they have, particularly in states where aid in dying is legal, physician aid in dying, whether they don't also have a duty to refer that patient to another who will talk to them, honor that request if that's what they want. And the difference between being complicit and being coercive. Thank you.
So, Mike, I have a question. So, are the people online able to hear the questions? Do we need to repeat those using mic? Do we have a portable mic for the questions?
I have a pretty loud voice. How could they not?
Okay, all right.
So I'm going to do the second one first and then go to the referral question. So thank you for the question. I think it's a big difference between complicity and coercion. There's a lot of things in between, and I think undue influence is probably more of a concern than coercion. My own view is talking about things, particularly when the goal of the conversation is the patient and the family do most of the talking, and the doctor asks the questions to draw them out and does the listening and tries to clarify. That is the opposite of either coercive, undue influence and complicity. I think that's just good doctoring. It's sort of helping the patient think through a decision. And I would hope that no matter how opposed you are to it philosophically or morally, you would be willing to have that conversation. I think complicity it's a word that's used a lot. I think it was the word of the year or one of the words of the year in 2017. What does it mean? Well, I think it has something to do with you don't want to be too closely associated with something you think is morally wrong. But what does that mean? Okay, certainly, and the Catholic Church has a very elaborate doctrine on this, which at least helps you see distinctions. So do you share the intention of the patient? Do you share the goal of the patient? And if you make it clear that you want to talk because you think that it's good for people to talk and to be listened to, if you want to provide information because you think a patient ought to have information about a decision, just as you would provide information. I don't refer a lot of people for cardiac revascularization if they're, not having unstable angina. But I tell them about it, even though I think it's not a good idea. So that's part of what we're used to doing, we doctors. I think the other thing about complicity is that directly supplying the means with the intention that the patient will use it for something that you think is wrong, I can see that. But that's very different than talking to the patient and listening to the patient. I would say providing information. Okay, now you go to, do you make a referral? Doctors have all kinds of preferences regarding practice. So I've referred people to specialists, and the patients come back and said, that didn't click. You've got to find me someone. So part of my job, I think, is to say, well, even though I may not agree with your wanting that particular mode of care, I think helping you find information is a good thing. I personally don't think saying there's all this stuff on the internet, and I imagine but the internet is wonderful, but patients actually like the chance to ask questions of the doctor, and I'm sure a lot of organizations provide counseling information. But there's something special about having had a doctor that's gotten you through one crisis after another. So actually, I would try and argue that giving information and making referral is very different than writing prescription. But I would argue that I know people disagree, and I know people draw the line. I think if you don't provide the information yourself, do you at least help the patient find a good source of information, which may be other doctors you've heard about, even though you don't know them personally. So I think, I guess what I'm arguing is don't be too quick to say, I will taint myself if I do even this. I think you can go a pretty long way, and the patient will understand that you're not supporting them on this, but appreciates what you are willing to do. Okay, that's a long-winded answer.
Hi, Ken Berkowitz.
Ken Berkowitz on the VA National Center for Ethics in Healthcare at NYU. But picking up on that, it strikes, I agree with you. We've managed many questions about provider rights of conscience, and I always think that personally, I think it's wrong for a provider to impose their values on a patient and not help work the patient through to a way where they can get their values to take priority. Do you think that in the past month that the landscape has drastically changed? I mean, HHS has new religious and moral objection rules. They've been giving $300+ million in the next year to implement them. And the specifics of it are that any healthcare worker, not just the provider, can claim an objection and doesn't have to talk about it, doesn't have to participate, or make a referral. It's explicit now.
Yeah. So
how does that change the landscape?
Well, it does, because it's an easy solution. You can say, I now have the federally recognized legal right to do that. But the real question is, is that the right thing to do professionally and morally? Just because you don't have to, and the law says you don't have to, does that mean it's automatically a case that you don't do it? Particularly, and I would argue, particularly as a patient that you've had for a long time, you've sort of gone through a lot of very tough medical decisions together, just in the way I think you suggested, Ken, which is sort of helping the patient clarify his values, explaining how those values might play out in a clinical scenario. To then say, step back, say, well, I'm going to protect myself so that I'm not, my conscience, my integrity aren't violated. That may make you feel better and may make you feel that your integrity has been protected. But what about the patient? Where does that leave that patient? Now, you could argue that if I'm sensitive, if I were opposed and I were sensitive, I would have something when patients first come to see me. Hope it doesn't come to that. I really believe in palliative care. I've got great palliative care referrals, specialists to refer to. But if it comes to a point where you want to ask me, I just want you to know, I'm not going to talk to you, I'm not going to refer, I'm not going to give you information, am I going to listen to your needs and concerns? Because I think it's really hard on a patient to start a relationship and then have the doctor say, well, I can't go further, particularly when in that relationship you have provided information, referrals, and talk people through it. So I think there's your own integrity, there's your responsibility to take care of patients in need, and there's also, I think, responsibility to give people fair warning about what's going to happen. Let me also just say there's a lot of problems these days because there's a lot of mergers going on. Hospitals are having real trouble financially. A lot of hospitals are merging. And it actually turns out to be there are clearly denominational hospitals, Catholic hospitals, evangelical hospitals, where their mission says, we don't write these prescriptions. But it may not be clear to a patient who signs up for their health care plan that that restriction is there. And that kind of makes it hard to make sensible choices about where am I, what plan and what hospital I go to. So that's, I think that there's more than one issue here. And you need to kind of, I would argue, kind of look at how your decision as a doctor plays out for the patient, for other patients. I haven't even talked about your colleagues. Right? Okay, I'm giving it too long answers, so we need to.
Actually, next one we would have the person online. So we have the question to online.
Yes, this question came online from a participant named Ashley Cardenas. And she asked if Dr. Lowe could provide any citations for the stats on patients who left a practice due to the doctor's position on MAID.
If you look at the Oregon annual reports, which are up on the Oregon website, they're there. And there's earlier references, one by Diane Meyer et al. At Mount Sinai in 1997 and 98 in New England Journal of Medicine. And another article by Zeke Emanuel and colleagues in either 1997 or 98. Those are both national studies, national surveys. The Oregon data is all the cases reported under the Oregon law, which qualifies you for legal immunity. Washington State has similar annual reporting. They're sort of a year behind. And then there's a masterful set of data from the Netherlands, which in addition to looking at the reports of physician suicide and active euthanasia, they distinguish them very carefully. And for reasons I'd be glad to talk about if anybody's interested. They also do a random sample of all deaths. So they know cases that weren't called aid in dying, again, active euthanasia, physician-assisted suicide, but in fact were. So that's probably, and, Holland is not us. They're going to win a lot of gold medals in speed skating. Whether we do or not's another thing. But there are data, and it's actually pretty good data. And I guess the challenge will be, what other data should we be gathering so that if we have this discussion next year, 2 years, 5 years later, we have up-to-date information that we think is trustworthy. So my bias is I sort of think data are good to have. They're good. It's important to be critical of them and to assess them, but evidence-based medicine's come a long way. So I would encourage you to, and there certainly are limitations of the Oregon and Washington data. Okay.
Yes, on this question of the right to not participate, as I understand it, Oregon gives doctors the right to participate, but not the duty, and I assume that's true for California as well. And you hinted something about you didn't think this was the same quite as that baker situation with the cakes, and I wonder if this would be in line with where you were thinking, or if not, say otherwise. It seems to me, I like to try to distinguish when we're talking about this in class, between the conscience of the person as a healthcare professional versus the conscience of the person more generally. So that if if a pharmacist or a physician refuses to prescribe or fill contraceptive on the ground that contraception is a sin, that's outside the integrity of the profession itself, and you would think, well, that person shouldn't really be in this profession. If, on the other hand, there's a lot of controversial data about whether this particular contraceptive is more adverse, unduly adverse to health. So I always think of this issue as one where conscientious healthcare doctors or end-of-life professionals can reasonably disagree about what's a good way, a sound way to help a person in dying. And therefore, I think this feeds into your idea that when you can discuss this with this person. Here's why I wouldn't prescribe this. There are other physicians who, if you go and discuss with them, they may take a different view. This is my view. It's a complicated issue or something. Does that help clarify the matter?
Yeah, you've said a lot of important things. Let me try and tease them out. One, I think the distinction between your personal conscience as a human being based on your own personal religion morality, that's something. Then there are doctors say, but wait, there's a professional role that I'm fulfilling as a physician. And I know that other physicians may disagree, but I think that if it isn't just my own personal belief, but really strikes at what does it mean to be a doctor, a professional, then that's a different set of arguments. My own sense is that in this country, we give a lot of deference to personal religious beliefs. I don't know, most of you, I think, have driven through Rhode Island on I-95, and so just zip on through. Roger Williams is a very interesting character, and he wrote a lot about conscience. And he pointed out that we don't necessarily agree with people about what's right or wrong, but we really want to defend their right to feel that their conscience is not violated, even though it's not popular. And he was obviously persecuted for his own personal beliefs. So this notion of religious liberty being linked to conscience, and conscience is a way of protecting minorities from the tyranny of the dominant religion in those days, Massachusetts Bay Colony. I think we've kind of lost sight of that. Now, that being said, you made some very important, interesting points, I thought, about professional. What is the medicine as a profession? What's the scope of our duties? So we disagree on a lot of things, right? There's a variation, the data aren't in, this patient doesn't fit the guidelines. And we are getting more comfortable with the idea that there's evidence, there's limitations of evidence, there's evidence-based guidelines, there's applying it to individuals, and doctors will disagree along the way. Part of what we need to do now in the new relationship we have with patients is to help them understand that divergence of views and opinions and help them think through the issues that they might want to think about as they kind of navigate through. So to the extent that we now are saying the definition of what a physician as a physician should do or should not do is contested, I guess is the in term, but it's something that we all don't agree about. But we should be willing to talk about it and just say, end of discussion, I'm drawing this line and everything else is out. It shouldn't, I would like to think it's not any harder than disagreeing with colleagues about whether somebody, should, whatever, you're a heart surgeon, have a heart valve replaced, or whether they could, just get bio-intensive, more intensive medical care. Okay? But these are all issues that, having thought through, am I going to support or oppose a ballot measure or write a letter to my state's legislator or sign a petition urging, your local medical site to support or oppose. Different set of questions altogether. Okay.
Let's have a question on the line.
Sure. This question comes from Jeff Struthers. He's asking, Dr. Lowe, do you envision further shortages in effective oral agents available for PAD? And if so, will that cause a push for availability of intravenous agents for patients to use? And will that, in turn, cause a further moral ambiguity between euthanasia and PAD?
Whoa, boy. Great questions. Thank you. So I think you have to put this in the context of very, very steep rises in price of drugs that are not on patent and formerly were really quite expensive, and increases of many-fold. I mean, the EpiPen, what's the drug? Yeah, but things that used to be generic drugs, and then the dapsone medicine. Saline, there are shortages of saline. So there's something really wrong with our medical system where you can just raise the price because no one else is making it. So the price of the formerly most widely prescribed, or most recommended, I don't know what's prescribed, drug for sedation was one in the barbiturate class. The price of that is skyrocketed, okay? And it's hard to get. It's not easy to stop. So what do you prescribe? You're gonna write the prescription. So there are now other suggestions, and again, if you go to websites, the doctors have gotten together with advocacy organizations to say, well, this is, in our opinion, a reasonable combination. And when you don't have data, you go to expert opinion. But we don't really know how effective these drugs are, what the side effects are. And we're not collecting it in a systematic way. So a year from now, are we going to have any better idea? But I think that this is embedded in all kinds of problems, and then is your insurance going to cover it? So the out-of-pocket costs to patients who actually go through and purchase drugs can be really substantial, like several $1,000s. That's a lot of money.
Is the price of the oral phenobarbital going up because of this, or that's just coincidental?
Well, that's another question, right? I mean,
One distributor.
it's one distributor.
It's a seller's market.
Yeah. And just that extent, it's no different than the EpiPen, right? And there's not a whole lot of incentive for, when you took, well, we called it Econ 1, whatever it was, maybe it was 101 in your college. In a free market, if you have more demand, the price is supposed to come down, right? This is not a free market in drugs.
Demand, though. There's not a huge number of people in Oregon that are requesting these medications. It's rather a small number.
Right, but nationwide, and you can export it to Holland and Belgium. No, it's not great, but these are not real expensive drugs to make either.
Absolutely.
Right? There's when drug companies say we have to charge whatever it is they're charging for the Hep C drugs, because look at all the R&D that went into it, look at all the drugs that failed. No, this is a generic drug, it's off patent, it's not that hard to manufacture. Okay.
Could I just say something about the side effects? I'm sorry. This is also tracked by the side effects of any of these medications that are used in Oregon and Washington are tracked very closely by the state. So anytime there are any side effects, they have to be reported, and they are every year.
They're not tracked relative to what was prescribed in the dose.
I beg your pardon?
If you read the reports, you can't correlate what was prescribed with what. So if you think about real-world evidence for efficacy and safety of drugs the FDA is trying to accumulate, you want to see what was prescribed and what doses and what the side effects are. So you're right, there's absence, goes back to a question for the internet. They'll tell you the incidence of certain side effects, but they don't tell you, they may have it and just don't publish it, what doses there were and are there enough cases to say, for this drug, combination drugs, you had these side effects. They're very small numbers, a couple percent. But yeah, I agree with the underlying premise. It's good to have that information. I'm just saying, until you can relate it back to the specific drug and the dosage, it's not as useful as we'd like to see in every other clinical study.
So you have another question online, and then
Great. This is a multi-part question from Ashley Cardenas. Dr. Lowe, you mentioned the need for physicians to support one another. Do you have any thoughts on medical, professional, and healthcare organizations maintaining positions of opposition to medical aid in dying versus adopting positions of engaged neutrality in order to support their constituents who are able and willing to provide this care to terminally ill patients while still respecting their constituents who are opposed?
Okay, there is a multi-part question. I think I made a slide. So let me again, what I want to try and do is normalize this for you. Okay, physician burnout is a really big issue, and I think any health organization ought to pay attention to the well-being of doctors who are in stressful areas of practice. So what are the sort of programs to help physicians deal with moral distress, emotional distress, burnout? So that should be, you should have a robust program in your institution. Now, a lot of institutions now, you hear things are going the other way, that there's a concern about margins, so people are being speeded up to try and see more patients, services are cut to save costs. So, there's a tension there. When a person is distressed, whether a doctor, a nurse, or anything else, you should deal with the distress without sort of saying, well, I kind of don't like the position that person took on this issue or that issue, right? So I think you want to try and keep your medical workforce, healthcare workforce, I'm not saying you have to get them up on the happiness quotient, but prevent burnout and have them continue to feel satisfaction in the job so they don't exit the field. We know something about how to do that. We haven't done the best job applying across the board. Now, in terms of, there's a middle part of the question I didn't quite catch on, is it constituents or?
I think it's like groups like the AMA, or in other words, for physician organizations, should they have a role in all this given the diversity of views?
Well, they have played a role. So the California Medical Society went against a former position saying we oppose it. So they sort of said, so yeah, it's professional organizations are not shy about trying to speak up for positions they believe in. And so every time there's a change in physician reimbursement, every time there's a plan to scorecard, your organizations, whatever they are out there front and center, supposedly doing it for the benefit of their constituent members. So again, I think it's one thing to say we're going to, as a group, oppose it or reject it. Organizations vary, they change their minds over time. But do you even say doctors disagree? Doctors are like the rest of society, they disagree. But I think in terms of supporting the distress that doctors feel trying to do a good job working with their patients, I think that's something we all should support.
And maybe, hi, I'm Betty Wolder-Levin. I'm at the CUNY School of Public Health. And if I could just make a very brief comment following that last question, there's also questions about what bioethicists, professional organizations should do about various controversial positions. But I was going to raise another issue.
No, that's a huge,
It's a
important
huge
topic.
issue, but for this audience, it might be of particular interest, and this one has an interesting history for students who are new to the field. In Canada now, they've approved medical aid in dying as opposed to physician-assisted suicide. And one can think of a range of various kinds of actions that physicians can do, including terminal sedation. And I wondered if you think that the set of issues are really the same for the whole range of options related to possibly hastening death or preventing prolongation of suffering.
Yeah. So I didn't bring my kind of end-of-life care, palliative care slide, but there's a whole set of things doctors do, from withholding interventions that might be life-prolonging, so writing do not attempt resuscitation orders, to withdrawing life-sustaining treatments, so the patient who's admitted emergently with profound hypoxemia is intubated, and then it's found out later that he didn't want to be intubated, he had really severe interstitial lung disease, so you can withdraw the ventilator based on family disease. Going through this, I have been a strong advocate of palliative sedation, which is using doses of sedation in the quantities needed to relieve a patient's distress, not exceeding the dose that's required, but being willing to go up if the lower dose doesn't work. So there's a proportionality. Now, as we go down that list, people get more uncomfortable. So I've argued that things I've talked about are all above the line, that every doctor should be willing to do that. And, you know, they've written about palliative sedation. If you will lose the least dose needed, but you are willing to escalate when the lower dose doesn't work, there is a foreseen but unintended adverse effect, which could be shortening the duration of someone's life. But that's not your primary. So then you get, but there are people who really disagree with that, right? And so then the argument is that within the scope of something everyone should do? Or can a doctor say, I'm not going to do it, and if they're the ICU attending that week, and they say, not on my service, you know, they call in a backup. Well, I had trouble with that is trying to do it as an outpatient. Okay, so an inpatient, you've got intravenous line, you can titrate, you can be at the bedside, check back. You can administer escalating doses of sedation in palliative care, but you don't have that very close monitoring. Okay? I've said to a patient, you know, we could admit you to an inpatient hospice facility. We have wonderful sort of called a palliative care suite where people can spend their last few days. There's a Zen hospital. There are other inpatient hospices. But patients say, no, I really want to die at home. That's the most important thing. And I don't want my family to have to deal with, should we give her a higher dose? Is that the kind of signal that the nurse and anesthesiologist would say, let's up the level of sedation? So, and you know, remember, there are people who don't qualify for home hospice. They may not have a home, they may not have a primary caregiver, they don't qualify for the medical. So, yeah,
So you wouldn't, if somebody did qualify in other ways for home hospice, you wouldn't be comfortable with something like terminal sedation?
well, terminal sedation is different in my view, so we have to be very careful. So, you know, there's finer lines here. One is just using a high number of milligrams of morphine if the lower dose doesn't work. And some people say, well, gosh, that's twice as large than anything I've written. Well, patient. Well, you probably need to rotate opioids, but there may be a reason for that. Palliative sedation to me is you titrate the dose upward to relieve symptoms. And I've argued that you take a pretty broad but plausible view of symptoms, tachycardia. Now, terminal sedation, again, people mean different things when they use the same term, and there's a lot of confusion. The Dutch data are actually the best of these. To some people, terminal sedation means you start with a dose that you intend to induce unconsciousness. And you just want that patient to be in a medically induced state of unconsciousness until they're done. And you usually withhold other things as well. And then the feeding tube issue gets wrapped around. So there's, the goal is to render the patient unconscious. Now, I actually have had cases where I thought that was a palliative care thing to do. So I took care of a patient once who had a DIC, a descending injurious coagulation from metastatic colon cancer. And he just had massive bleeds, you know, really massive bleeds. You don't want someone, it's just, it's a dioic segregation isn't the kind of death anybody should have. But the only way you control that is to make the person hypotensive, and so they're at least unconscious. You know, I have the utmost respect for hospice. I once, in this patient, I called the best hospice, said, what do you do in that situation? They said, tell the family to buy green towels. Because of the optics, if you have a green towel, the blood doesn't look as awful. This man had married late in life. He had a 6-year-old daughter who he wanted to spend time with. He didn't want her to have the last memory of him exsanguinating. So, you know, but that's really different. The proportionality is important, and our Catholic colleagues who understand their own doctrine will make a really big point of that. And I think it is important. Okay, so I've said a lot and probably talked too much.
Well, and I wonder if you could at least briefly talk about the other side with medical aid in dying, because I went to a conference with Canadian and European doctors who had trouble with physician aid in dying and suicide, and I hadn't known it, that somebody could see that as more problematic than medical aid in dying. That was a whole new...
Well, different cultures, different countries have different cultures. So we've talked about individual differences. We've talked about institutional differences. Different hospices will take different positions. Different countries clearly have different positions. And what's really interesting is that most countries tend to be blind to their own inconsistencies. And you know, I have the utmost respect to how Holland has really collected the most rigorous data on how people die. Just every which way, qualitative interviews, epidemiological studies, chart reviews, you name it, and they all bring it together. But their early data showed that their own guidelines weren't being followed in some cases. And a lot of people would go there and say, oh, this is awful. You know, probably don't want to go to someone else's country and say, oh, this is awful, and you know, you don't really understand it. But they would say, no, we don't see a problem. They very rarely use assisted suicide because they had so many problems early on with really serious adverse effects. So most of their assistance in dying is actually active euthanasia administered by the doctor.
And Canada chose that, which I'm still.
Obviously, there's a lot more to talk
There's
about.
a lot more to talk about. Anyway, so.
Unfortunately, we're out of time, but this has been great. Thank you so much. Please join me in thanking Dr. Lowe.